we have our special invitee from the Bulgaria, that is Dr. Svetoslav Hristov. He is from the town of Shoman, Bulgaria. Currently, Dr. Svetoslav is working as a veterinarian in the United Veterinary Clinic, Varna, Bulgaria. Dr. Svet's professional interests are traumatology, orthopedics, neurosurgery, then rheumatology, reconstructive plastic surgery. He is actively involved and trained in Europe and USA for performing the many advanced surgical techniques. For example, I would like to give some examples like knee surgeries, limb corrections and lengthening surgeries, hip arthroplasties, and many others includes in the many advanced techniques. Today, Dr. Svets is joining with us for discussing about the use of llizarov in the small animal practice and its comparison with the linear external skeletal fixation. Dr. Svetoslav is currently a chairman of the Bulgarian Association of Veterinary Orthopedics and Traumatology, and he is an active person in the Bulgarian Association of Veterinarians for the Small Animal. And moreover, I would like to include that Dr. Svet is an AVO-VET, part of an AVO-VET, which is a world-class organization for training the veterinary postgraduates for the training physicians. And it is our honor to have Dr. Svetoslav with us today. And I would like to ask everyone, please be with us throughout the webinar so that we can learn many things from Dr. Svet, and keep supporting us and have a happy learning. And thank you all. And with this, I would like to hand over to Dr. Svet. Doctor, and the screen is yours, and you are welcome.
Thank you, Abhishek. Thank you very much. I will just start sharing my screen. Again, thank you very much for your kind invitation. First of all, personally to you, and then secondly to the institution that you present.
Yes.
I think this pandemic situation it's bad for everyone, but at least gave us this opportunity to meet many people, from very far countries. So for me, it will be difficult to travel to India, but by doing a webinar, it's going to be very easy to share my experience with you and with your colleagues in India.
Yes, sir.
So I'm starting with so the topic today is to share my experience and to give you a little bit of knowledge about external fixation as a method, and also to compare a little bit about the different type of external fixators and different type of external fixations that are available. So do you see the second slide?
Yes, sir, we can.
Okay, yeah, just I wanted to make sure that you see everything. So the learning objectives of this webinar will be to classify different ESF systems and frame configurations, to also formulate the principles for application of ESF, to understand the biomechanics of different frame types, to describe indications and some contraindications, and also to share some personal experience in a case-based approach. So this method, actually, it's definitely one of our best friends in treating especially fractures in small animals. And this statement, I like it a lot. The ESF is the small animal practitioner friend given by Ross Palmer. It's an American surgeon that also he dedicated a lot of his work to external skeletal fixation. So if we think about the different aspects of treating fractures, which are the mechanical, the biological, and the clinical aspect, we can say that the ESF is actually the best biological way to treat fractures, because we can apply it even in a closed fashion without, opening, without manipulating with the fracture line. So this will be the best biological approach to a fracture, which is already compromised in terms of biology and blood supply. Also, it's very safe for the soft tissue that surround the fracture line. At the same time, from mechanical point, if we can make a good construct following the principles of external skeletal fixation, we can build a very nice frame which will counteract all of the 5 fracture forces. So in terms of mechanics, also, this is kind of a very good way to stabilize a fracture. Probably the only problem we have with the clinical aspect, because external skeletal fixation, unfortunately, is related to some morbidity to the pet. It's the same for us, for humans. I mean, if I need to have external skeletal fixator, that's going to be related also to some morbidity. Also, this method requires a very dedicated owner. So the owner should be on your side in order to follow your instruction and to make sure that the post-operative period will go smooth. So, as we say, there is no full happiness in this world. Most of the external fixator characteristics are pretty nice for treating fractures. And also, we always think about external fixation in terms of financial aspect, because I live in a country, we are relatively poor Eastern European country, and the financial part is always in a big consideration when we treat fractures. And also, external skeletal fixation allows you to do this in a relatively, to treat fractures in with a relatively low cost. So I think this is also a kind of advantage. So it's definitely ESF is easy to apply, and as I mentioned, more biologically oriented fixation method. There is no implants at the fracture site, and this is very important, especially when we treat open fractures, and especially if there is no soft tissue to cover the fracture line. So, for example, if we have a deficit of a big deficit of soft tissue, or if we are treating, let's say, infected fractures, osteomyelitis. As I mentioned, efficiently control all fracture forces. And also at the same time, we can play a little bit with the rigidity of the construct. So this can allow us a little bit of micro motion, and this micro motion is very unique only for external skeletal fixation. So we can make things a little bit unstable, but in a degree that it still will have bone formation. But again, we can play a little bit with this. It could be combined with another fixation methods, and also the other advantage is that we easily remove the implant. So if I have to remove a plate, for example, I have to do the same soft tissue approach and skin incision in order to remove the plate at the same, like, when I apply the plate. With an ESF, it's completely different. Just a slight sedation or anesthesia, and you can easily remove the implants. What are the type of ESF? We can say that there are 2 major types. One is the linear, and the other one is the circular fixators. The linears, they can consist of systems with the metal clamps, like the one on the first picture, or could be free form. This is the one on the second picture, which is the transarticular frame, which is made of epoxy. So this epoxy makes you a little bit of artist, so you can make any kind of configuration that you can have. On the other hand, the picture on the bottom of the slide is the circular fixator, where we have a combination of rings made of different materials. We'll go further more in details about the circular fixators, connected with the pins, which are relatively thin pins. They are K-wires, which are put under tension. And they are fixed again with the external frame, which are connecting rods. Most of the time, they are fully threaded connecting rods. And somewhere in the middle is the hybrid fixator, which is a combination of linear and circular one, which gives pretty much the advantages of both type of fixators. So I will go first a little bit about, speaking a little bit about linear external fixators. Again, the components of the linear fixator are fixation pins. The fixation pins actually with the linear fixators are probably the most important part, because actually the weak part in the linear fixator is the interface between the pin and the bone. And that's why we always recommend to use not a smooth pins, but to use a threaded pins, because the threaded pins gives much better stability into the bone in terms of the pull-out forces. Then we have some sort of external frame. These are so-called connecting rods. These connecting rods can be made of different materials. The most popular are probably the stainless steel, but they can be made of also aluminum or carbon, which is also X-ray negative, so you can see actually through these carbon rods. And also there are some sort of linkage devices. This actually connect the pin to the connecting rod, and they can be very different in terms of shape. You know, most of the time are made of stainless steel or aluminum, and again, there are a huge variety in terms of manufacturers. Then I have to mention about frame configuration, because this is an important part of the mechanics in external skeletal fixation. Based on the position of the connecting rod in relation to the bone, we can describe that there are 3 different frame configurations. Type 1 means that the connecting rod is positioned only from one side of the bone, one side of the leg. That for the tibia, it's usually the medial side, because the pins are inserted from the medial side. Then this type 1 can be also further divided in 2 different subtypes. Type 1A is when we have the connecting frame only from one side and then in a single plane. But then we have type 1B, which is also from one side, but then we have 2 connecting rods, which are at approximately 90 degrees or less one to each other, but they create 2 different planes. And this is important, and for example, for building an external skeletal fixation to the radius, where we usually prefer to use a type 1B frame. And also in type 1, all of the pins are only a half pins. Half pins means that they penetrate only from one side, so they penetrate the near skin, then both cortices of the bone, and then they do not penetrate the opposite skin surface. The only problem with type 1, and especially type 1A, when we have only one connecting bar, is the stability, especially in terms of bending and shear forces. So this is the weakest possible configuration frame. And we have to think about if we are building a frame to stabilize a very complex, let's say, highly comminuted fracture of the tibia, in which we expect a longer healing period. And as we all know that the fracture healing, the fracture treatment is kind of race between bone healing and implants loosening. We don't want to have loosening of these pins into the bone in a shorter period before we have a fracture healing, before we have a bone consolidation. So there are different ways to increase the stability in terms of bending in type 1A frame. And for example, one of the recommendations is to try to spread the pins along the bone. So we will always, when we apply external fixator to a bone, we want to follow the principle of far, near application of the pins. This means that we position our most proximal, most distal pin as far proximal and as far distal to the bone. And then the 2 pins that are close to the fracture line, we try to position them as close as possible, but of course we follow some other rules that the pins should not be really close to the fracture line, but we should insert these pins at least, let's say, 2 or 3 pins diameter away from the fracture line.
This is wrong.
So let's continue with the other option to increase the stability in terms of especially bending and shear forces in type 1A, and this is to let's say keep the connecting bar as close as possible to the bone. This is not absolutely possible because we have another rule with external skeletal fixation that the connecting bar should stay away from the skin at least 1 finger distance, because we need to have room to clean. Sometimes there is a reaction around the pins. We need to have room to have the skin actually free around the connecting rod. But at least we can try to apply this connecting rod close to the skin. Then we can put something like it's called double stack bars, so 2 bars together to prevent from these bending forces. Or for me, probably the best way is to simply build type 1B configuration frame. Because again, in terms of stability and especially in terms of bending stability, type 1B, it's a very strong configuration. So the application, clinical application of type 1A especially, it's probably a young dog with an undisplaced fracture of the, let's say, radius or the radius and ulna or the tibia and fibula. And actually, for me, this is a very nice application of this so-called wide configurations of external skeletal fixation as alternative to, for example, splintage or casting, because I'm really not a big fan of using external coaptation like splint or cast especially in growing animals, because we all know the complications that they can bring. So in these cases, I would prefer to simply build a simple or wider, as I mentioned, external fixation frame. And that's a very effective, and also the bone heals much faster. The owners are not so related to, again, to some care after splintage or casting. Type 2 configuration is a configuration when we have connecting bars from both sides, so from the medial and lateral aspect of the limb. In these cases, in this configuration, we are using the so-called full pins. Full pins means that the pin penetrate both cortices and both skin surfaces. Also, we have subtype differentiations in type 2 configurations. We can talk about type 2A when we have all pins as a full pins, but we can build type 2B when we have only some of the pins, usually is the most proximal, the most distal, as a full pins, and then the rest are just a half pins. So type 2 is stronger than type 1. Probably there is a little bit of when we talk about the bending forces, type 1B is actually stronger than type 2 configuration because we have 2-plane configuration. But type 2, as I mentioned, is really a strong one, and it should be built in the cases where we expect a longer healing period. And gunshot fractures are another nice examples for indication for external skeletal fixation, because again, we already have very compromised in terms of biology fracture line. So building external skeletal fixation in a way following the principles of minimally invasive osteosynthesis gives the best chance to the bone to heal. In this case, you can see in the picture in the middle, in the X-ray, that the one of the connecting rod is it's a X-ray negative. So you can see that's a carbon rod. The other one is a stainless steel rod. Then we go to the most rigid configuration, and the most complex one. This is type 3. Type 3 actually combine type 2 and type 1. So this is a configuration when we have we have 3 connecting bars, so from cranial, medial, and lateral aspect of the limb, and we have combination of full pins and half pins, and we have 2 plane of fixation. So again, this creates a very, very rigid fixation. Another variation of type 1 configuration is the so-called tie-in configuration. This is where we combine just a lateral frame with an intramedullary pin, and we connect them together. And this is the most common configuration that we build to the femur, especially in cats. So what are the principles of application of ESF? First of all, as I mentioned, this is a very, when we speak about ESF in the lower bones, like the radius and ulna and the tibia, we usually do it in that way by hanging the limb up. This will restore the alignment of the fractured bone, first of all, and then will give us freedom, like 360 degrees freedom to move around the limb and around the animal during the surgery. And this is important, especially if we build a more complex frame. So during the application of this ESF of the lower limb, usually we keep the limb extended in this position during the whole surgery. Then we need to find which are the most proximal and the most distal aspect of the bone, of the fractured bone. As I mentioned, that we are following the rule of far, far, near, near. So this, for doing this, we need to know a little bit of anatomy, of course, and to find which are the joint spaces. And we can even mark the joint spaces with a hypodermic needle. Then we palpate the anatomical landmarks, for example, this is a radius and ulna case, and so we need to find the steroid of the distal radius and the head of the radius of the lateral aspect proximally, and then we can mark the joint. The application of external skeletal fixation pin should be done always after release incision of the skin. So we need to do a relatively wide incision, because we don't want the skin to interfere with the pin after the pin has been inserted to the bone, because this may create some sort of inflammation and produce the so-called phenomenon of pin loosening. And if this is done again prematurely, so before bone consolidation, this means this may lead to removal of the frame before we have actual bone healing. So we need to also know what are the safe corridors. So that's the safest areas for each bone that we can apply, insert our pin before without the pin to interfere with the big muscles, blood vessels, especially nerves, which could be devastating. And speaking about safe corridors, as I mentioned, there are safe corridors for each bone. The tibia is probably the easiest bone, so if you don't have experience with external skeletal fixation, we always recommend to start with the tibia, because actually the entire medial aspect of the tibia, it's a safe corridor for inserting our transfixation pins. Actually, the tibia is always the best bone to start with any procedure in terms of fracture treatment. The entire lateral aspect is a hazardous, so there's some risk to insert pins there, but we do it actually, especially if we have to build a type 2 or type 3 frame. And some cranial medial aspect also of the cranial aspect of the tibia is also considered as a safe corridor for pin insertion. When we talk to radius and the ulna, the entire distal medial aspect and part of the cranial aspect is considered, actually the distal 2/3 of the cranial medial aspect of the radius is considered to be as a safe zone with low morbidity to place your fixation pins. The rest, unfortunately, is kind of hazardous, but again, it is possible to build a complex frame to radius and ulna. Unfortunately, I have to mention that the upper bones, so that the humerus and especially the femur, are not the best bones for application of external skeletal fixation. Humerus probably is not so a problematic bone, and I think we all do a lot of cases, a lot of ESF cases to humerus. But the femur is actually, I definitely try to avoid the femur, and especially in dogs. Unfortunately, statistically and historically, ESF application to the femur, especially in growing animals, it's very often related to some contraction of the quadriceps that could lead to actually devastating quadriceps contraction with this hyperextended knee and recurvatum. So sooner or later, if you are using ESF in the femur, probably you're going to meet this complication, and definitely this is not a complication that you want to deal with. But as I mentioned, humerus, it's relatively a good bone, upper bone to deal with ESF, especially this tying configuration. It's very easy applied to the humerus. The humerocondyle, it's a very dense, very nice bone. That it's the best location for one of your transfixation pins. You have to stay away, of course, in the distal 1/3 of the humerus or the lateral aspect when we have the radial nerve passing. And you have to consider that the proximal aspect of the humerus is relatively a soft bone with a thin cortices, which doesn't create a very good stability to your transfixation pin. As I mentioned, a femur, it's a little bit more complicated bone for to be used with external skeletal fixation, and it's related actually to a lot of morbidity. So this is why we try to avoid it, because you have to pass, you know, some of the pins should pass through the big muscles, and this will create a lot of morbidity and pain to the patient. And you can compare actually this X-ray here. This is a very old X-ray, and I'm definitely not proud with what I did here. But you can compare the femur with external fixation frame to the other one, and you can see the difference in the muscle mass. So the quadriceps muscle mass, it's really atrophied on the side of the external skeletal fixator in comparison to the one with the rush pinning on the opposite side. But again, in cats especially, you can use these tie-in configurations into the femur fractures, and it's a very nice and way to treat these fractures, but again, only in cats. There are also principles of insertion of transfixation pins that we need to follow, and this is very, very important. As I mentioned in the beginning, in the linear external skeletal fixation, the most critical point is the interface between the pin and the bone. So we must follow the rules of application of the pins, and especially if we are using a threaded pins. And first of all, we have to follow the principle that our size, the pin size diameter, should be not bigger than 25% of the location where the pin is going to be inserted into the bone. And I'm saying location because, for example, the tibia could be with a different diameter proximally. It is a bone with a different diameter proximally into the middle. Same probably for the humerus. So you can combine actually different size pins, but you should stay with this 25% of diameter of the pin in comparison to the bone. Then we have to center the pin into the middle of the bone, so we should not go through the cortex, because drilling through the cortex will create a lot of heat, and this is not good for the bone. We need to pre-drill. That's a very important rule. So the drill, we should use the drill approximately 15% smaller than the outer diameter of the fixation pin in order to allow the debris of the bone to escape during drilling. And this is important because once we insert the transfixation pin later, then will be less friction. So it's going to be like a screw applied to the bone. So for the same reason, we are using a drill bits when we are making a hole for a screw in the bone, when we are using plates and screws, for example. It is absolutely the same principle here. Despite that the pin should be with a sharp end, we always have to pre-drill. This will reduce the friction while we are applying the transfixation pin. This will reduce the possibility of this pin to be prematurely loosed later on during the fracture healing. Okay, so we drill first, we create a pivot hole, and then we insert our transfixation pin. A little bit about the post-operative care, which is also very, very important, as I mentioned in the external fixation method. We need to stabilize. One important thing is during especially the early period of soft tissue healing, is to stabilize the skin around the pins. So we don't want this skin to move too much around these pins in order to keep the sterility of this area, to prevent bacteria to go inside to this skin incisions. And this will form a crust that is sterile, or it's going to heal in the way so the bacteria cannot penetrate through this skin incisions. We need to control patient activity, of course, but the beauty of external skeletal fixation is that we can provide actually early limb use. And this is also good for the bone, because we know that the bone needs mechanical stimulus to heal. Otherwise, it's not going to heal. So the animal should bear weight on that leg as soon as possible after applying the external fixation, external fixator. So I would like to show you some cases with using a linear external fixator. This is a gunshot fracture of the proximal humerus. You know that proximal humerus is not very common location for fractures because the bone is actually much wider in this area. So if we have a fracture of the humerus, it's usually somewhere in the mid of the mid shaft of the humerus, or it's going to be close to the joint. So fractures of the proximal part of the humerus are usually a gunshot fracture or pathological fracture. So you have to be always aware about possibility of osteosarcoma. This is a young dog, of course, and it's a very obvious that it's a gunshot fracture. In this case, we applied the two some sort of type 1B frame to the humerus in a closed fashion. So this means that I apply these pins under rentgenographical control in order to be able to insert 3 pins in this relatively small area. And this is the best biological, fixation that you can do for this bone. And so it's not unusual to see a nice bony callus formation in approximately early stage of after the application of the external fixation, external fixator. Another application of external fixator that I like, it's this transarticular fixation. Cases like a shearing injury of the distal limb, especially to the tarsal joint, like in this case, this is a young Doberman. It's not a young, sorry, it's a, I think 5 or 6 years old Doberman that had a shearing injury of the tarsus and metatarsal area. In these cases, if you still have approximately 50% of the cartilage preserved, you can stabilize temporarily with a transarticular frame. Lets the tissue to granulate, lets the granulation tissue to fill the skin defect, and then wait for epithelialization. And at some point, that's usually 6 or 8 weeks after the treatment, you can actually. Sorry, I made a mistake. Can you see now my slide?
Yes, sir. Yes, sir. We can.
Yes, sorry for that.
It's okay.
So in these cases, by providing a temporary stabilization of this sheared area, you can allow granulation, epithelialization, and also some kind of fibrosis around the joint. And we know that this works very well, especially for the tarsal joint. So this is the dog after the treatment. So it's the Doberman that you can see running, and you can see that in terms of functional, I mean, there is a slight lameness, of course, but at least this dog has a good functional hind limb. And there are some other cases like this, when there is really a huge soft tissue defect. And again, by providing stability of the transarticular stability, you let the soft tissue to heal. And sometimes you are amazed actually how good, the soft tissue is healing the area. Some transarticular application of linear external skeletal fixation can be used for, let's say, temporary stabilization after you stabilize with some sort of internal fixation or perform prosthesis of ligaments. And this cat, for example, is a cat that was presented to us approximately 1 month after the trauma. So we already had, and the cat had an interarticular ulna fracture with a dislocation of the ulna joint, of the elbow joint. So the first treatment was done to the left leg when we restore the ulna. So we treat the ulna with the plate and screws. We also restore the stability of the joint using collateral ligaments, or prosthetic collateral ligaments. And then, unfortunately, during the treatment of this leg, we applied this linear fixator with a hinge, which allows flexion and extension. So we don't want to freeze the joint for the postoperative period. We want to let the joint a little bit of movement, especially flexion and extension, because this is for the health of the joint is very important. And we can build such a transarticular frame. This cat, unfortunately, for the time of being treated for the second leg, we realized that we cannot repeat the same procedure, and we straight away perform elbow arthrodesis. And you can see actually the functionality of both elbows. So the left one has been treated with this method. The right one was treated with arthrodesis. And you can see that actually there's a much better movement in the elbow joint on the left side in comparison to the right one. The right one has a lot of abduction, to accommodate the gait. Also, another thing that you can, another application of external skeletal fixation in small bones are these spider frames, where you can treat a relatively proximal or distal fracture of the meta bones, metacarpals or metatarsals. And just using this epoxy or acrylic material, you can free-form your connecting rod, usually like in this case. So you can be also a little bit of an artist here. I have to mention that usually when we talk about bone healing with external skeletal fixation, doesn't matter if it's a linear or circular one, we usually see the so-called a secondary bone healing, when the bone healing process goes through inflammation, repair, and remodeling. So we have relatively bigger callus formation. And this is especially true for the circular fixators. For the linear one, if we build a very strong frame, like type 2 or especially type 3, we may have some kind of stress shielding effect to the fracture line, which actually we don't want to see. I mean, we want the beauty of external fixator is that we can control the production of bone in the fracture line. And we always happy to see, some kind of relatively bulky bony cows with this method, because this means that we have created enough stability for bone healing, but we were not very, rigid with our external fixation frame. So I will continue with the ring fixator that probably is a little bit more interested for you guys. I don't know what is your experience. This presentation, especially for the ring fixator, it's not going to focus too much about details, how to build the frame, and etc., because I think this is, aim for a course. It's a topic for a course to practice, to get really familiar with the method. I will show you some basic things just to have the knowledge how works this method, and again I will show you some clinical cases and my personal experience. So this method has been discovered and established by a Russian surgeon, Professor llizarov, and that's why it's the name of the method. It's given to his name. He was actually had to work in a very bad era where there was after the Second World War. So he was facing a lot of cases of non-union, bone non-unions, infected fractures or malunions. Also, in a time when there was a lack of supplies and lack of facilities, so he really had to invent something with a low cost to work, for treating such a pathological conditions. So llizarov brought the techniques to the human orthopedics, to the human field, but we should mention Antonio Ferretti, who is probably the surgeon, is a famous Italian surgeon who brought the method to our patients, to dogs and cats, and not only, because also the ring fixator has been applied to a lot of different species like horses, wild animals, birds, and etc. So Antonio Ferretti actually brought the method to Europe, and the person on the right picture with me is Dennis Marcin Lidl, who brought actually the method to United States to also dogs and cats. So my kind of adventure with the llizarov llizarov fixator or ring fixator started in Italy with these two guys because they made a very nice course in Cremona with Shivak, which is the Italian Small Animal Society. And if you have opportunity to travel to this course, I would strongly recommend you to do it, because it's a very detailed course with the faculty that are really good with circular fixation. So the advantages are pretty much the same like what we discussed with the linear external fixation. The only thing that we can add here is that the ring fixator allows you to make a new bone. And this is not only in terms of the bone formation in the fracture line, that we mentioned that there is a kind of micro motion into the fracture line, or we call it a bone gymnastic. So this produces a new bone in the fracture line, so stimulates bone healing. But also you can bring one segment of the bone to the other by lengthening, performing lengthening of the bone and the entire limb. Actually, this lengthening affects not only the bone, but also the soft tissue, the blood vessels, and the nerves. And this has been confirmed in many studies and in many cases, of course. Also provide excellent resistance to bending and rotational forces, because it's like a 3D frame form around the whole limb. So it's the components of circular fixators are rings. These rings can be made of stainless steel, but also they can be made of carbon or aluminum. The advantage of aluminum and carbon material is that this makes the entire configuration, the entire frame much whiter. And this is especially important when we treat small dogs, cats, when the weight of the components are really important. The design of these rings, the geometry of these rings, they could be full rings, but sometimes we need to use like 2/3 rings, especially if we build a frame close to the, for example, in this cat, you can see that the proximal and the most distal rings are actually 2/3 rings, because they should allow flexion into the stifle, and also flexion extension into the paw in the tarsal joint. And also we have these stretch rings or arcs that could help us in, again, bringing in the making our configuration. The connecting rods, they are usually threaded connecting rods with the various lengths. For hybrid configuration, which I'm going to mention a little bit later, which is a combination between circular and linear external fixators, we can use also partially threaded connecting rods. Another component are bolts that fix actually the pins to the rings. These bolts are cannulated or slotted ones. So through the head of these bolts, we actually insert our smooth pins, smooth K-wires. Sometimes the wire goes through, through the center of the hole of the ring from one side, but then exits from a little bit eccentrically from the other side. So to be able to fix it from the other side, we need to use the slotted part of the bolt. We also have washers that tie the bolt to the ring, and at the same time they keep the K-wire fixed to the ring. We may need also nuts, articulating joints. This is something that a component that we're gonna discuss about in soon when we are discussing about correcting of bone deformities. We have also posts. So posts are the component that can keep the pin or the K-wire or the pin away from the ring. Pins and wires, again, are very important part of our fixation, because they actually fix the bone to the external frame. The biggest difference between a linear and circular fixator is the fact that with the circular fixator we are using thin K-wires with a small diameter, usually up to 1.6 millimeter, or let's say 1.8 millimeters would be maximum. And despite that they're very thin, they're very strong because we put them under tension. So we are using a special device to tension these pins, and a pin with a diameter of 1.6 millimeter, it's strong enough, like a 4 millimeter threaded pin in a linear fixator, for example. We also follow some recommendation what should be the diameter of the K-wire in different sizes of dogs. This could vary, of course. We can have pins with a small bows or integrated along the length of the K-wire, which are called olive wires. They could be applied from two different direction to a fracture line, which is, for example, a brick fracture line to create some sort of compression in the fracture line, or to prevent from translational forces. Shunt pins are relatively big pins. They are usually at least 4 millimeter pins. They are sometimes used with a single when we have a fracture line very close to the one end of the bone, and we want to combine one ring with 4 pins and connect it with additional shunts pin. I will show you some cases to become more clear. So the pin tensioning, I already mentioned that there is actually a special device, again, a different design given by different manufacturers. And this device are graduated, so you know how much tension you put on that tin pins. And there are also some rules that we follow for pin tensioning. And then we have to mention also that actually the stability of your pin depends on how much tension you put. So if we say that in linear external skeletal fixation, the stability depends mainly on the interface between the pin and the bone. Here, the stability depends mainly on how much tension you did to your K wires. So this is really important part in terms of the mechanics of the configuration. As I mentioned, I will not go through details about the insertion of the and assembling the insertion of the pins and assembling the apparatus. I can mention that actually we try to create a so-called two-ring box. This means that the proximal segment is fixed with two rings, and the distal segment is fixed with two rings, because in terms of stability, this provides the best stability. So on each ring, we apply one K wire proximal and one K wire above and one K wire under each ring. Sometimes, if we deal with the fractures which are close to the joint, close to the metaphysis, it is impossible to apply two rings, so a ring block. In this case, we apply a single ring to this area, to this fragment. Again, could be the distal or the proximal one. But then we applied a second wire, which is called drop wire. The drop wire can be fixed in a different way, as you can see at the bottom of the slide. So it depends how much room you have in the distal fragment. Sometimes you really don't have, so you need to stay relatively close to the ring, but then that pin should not interfere with the other pin that was already applied on the top of the ring. So you can simply use a little bit of spacers, like a couple of washers, for example, or then you can use these components that I show you in the beginning, which are called posts. So this post can be with a different height, so you can put them in a different distance in relation to the ring. Sometimes in these cases, you can apply actually not a K wire, but again, you can apply a shunt pin, that pin that is relatively bigger. I already mentioned that we try to apply two pins for each ring. And this is not enough in terms of stability, but also it's important to position these pins at least at 60 degrees in order to provide a better stability. So if you go to 90 degrees, that will be even better. So that's going to be the best position, the orientation between these two K wires for each ring. Between 60 and 90 degrees is acceptable, but under 60 degrees, then you provide a poor stability. So this could not be, a stable configuration. We have to think about, in terms of stability, that we have to choose the smallest diameter of ring as possible, because if you go with the bigger rings, then the working length of the pin, this means the pin that is fixed to the bolt and goes to the distance of the pin between the bolt and the bone, it's going to be longer, this distance. So this will provide a longer working length for the pin. So everything will be a little bit more elastic. So we try to stay away of bigger rings. So we try to use a relatively smaller diameter of rings. But again, remember that you need to have room for cleaning and manipulation around the skin. So at least one finger rule should be also followed as a principle also in the ring fixation. Okay, method of application, as I mentioned, we actually applied the method to pretty much the indications are pretty much the same. I would say that maybe I use llizarov less right now in these days for fractures, because it's a more complex, more complex frame. It takes more time, and etc., etc. So if I could treat it with a linear external fixator, I probably choose to treat it with a linear external fixator. But there are cases where the circular external fixator is actually more appropriate than a linear one. Bone non-unions and false joints or pseudoarthrosis are good indications for llizarov. Bone deformities, definitely this is probably one of the pathologies where I am going to use llizarov. And for bone transport and lengthening, bone lengthening, actually there is no other opportunity, there is no other possibility, and this is kind of unique application for llizarov method. Joint arthrodesis I don't consider as the best application for circular fixation. So this is a case of very juxtarticular fracture, so a fracture that is very close to the tarsocrural joint. It's a highly comminuted fracture. So in terms of biology, we can say that even looking on the X-ray, without knowing anything else about the animal, we can say that it's a poor biology for this fracture. So we need something to preserve the blood supply and bony hematoma around the fracture line. If we know the history, I can tell you that this is an old German Shepherd. So this makes things even worse because, as you know, German Shepherds, they have a very bad quality, bone quality. They have a relatively thin cortices, so the implants doesn't hold very strong, in such a cortices. So if I decide to, if I have to judge and take a decision, should I use a linear external fixator, which is possible probably in this case, or circular one, I would definitely, my decision will be toward a circular one because of the bone quality. As I mentioned, the pin bone interface, it's going to be really, really critical in a linear external fixator. And I don't want to have my fixation pin to get loosed prematurely before bone consolidation. So in these cases, I would prefer to use a llizarov frame in order to put a good tension on my pins in order to provide enough stability. And this is how the bone has been fixed. Again, the distal in the distal fragment, we cannot apply a ring block. We apply just a single ring with is a drop wire. Unfortunately, I couldn't find the follow-up radiograph, but this was a case that we lost it for a very long time, and then the dog appeared, let's say, after a couple of years for some other problem, and then I took advantage to make a good X-ray because the frame was removed from another veterinarian, as far as I remember. So we had a very good bony consolidation in this case. This is another case with a good application of with a circular external skeletal fixation. It's a young mixed breed dog that was treated somewhere, and this was the situation when the dog was presented to us with a non-healed fracture of the femur with some loose implants, of course. And also non-healed infected fracture of the tibia with osteomyelitis and loose implants again. Plates and screws were originally used for treating of this fracture. So of course we did remove everything. I started with the femur, creating a plate rod construct to the femur, and then I was thinking what to do for the tibia, and I decided that I'm gonna do stabilization with a circular frame, and that big defect that was lost in the middle, while after I removed the some dead piece of bone, the osteosequestrum. We fill it with a piece of the ilium from the pelvis. So just a piece of bone was applied, and then we compress a little bit with our llizarov apparatus. And there was a bony consolidation, fracture healing and bone consolidation in a relatively short time after that. So that was a successful treatment. And this, for me, it's a good example of indication for llizarov fixators. But that's the other view. This is a very, very old case. Probably one of my first experience with llizarov at all. It's a small dog. It's a Bichon that was presented to us with after the dog has been treated with some internal fixation for probably was a simple fracture of the tibia, but then the dog developed osteomyelitis. Everything was removed. Then somebody tried to treat this fracture with external fixator, and then actually when I saw the dog was this condition was like what you see on the right images, with just the proximal and distal part of the tibia and some big holes, especially into the distal part. The good thing was that the fibula was healed, and because it was, you know, the single supporting structure for the leg actually was quite bigger than a regular tibia. So in this case, I decided that I need something bigger as a segment, as a bone segment. So in the previous case, I was using a piece of the ilium, but there was no. Here we needed something longer, so I took a piece of the distal ulna, which was applied into that segment that was missing into the central part of the tibia, fixed with the llizarov, and then from both sides at the interface between this cortical bone graft, autogenous bone graft, we applied also a cancellous bone to stimulate osteointegration between this free segment. So it was really nice to follow this case, that it actually healed in a quite longer time. I think approximately 4 months took for consolidation. And the good thing here, and we were lucky again that the fibula was providing also a lot of stability. So this dog lived many years after the treatment with a reasonably well-functioned hind limb. Of course, a little bit extended probably into the hook joint. Probably we didn't restore the entire length of the tibia, but at least again the leg was functional. Malunion, as I mentioned, are another another indications for using of llizarov. Here we're gonna mention a little bit the concept of deformity treatment, deformity corrections with the llizarov. In these cases, we are using a frame apparatus that has articulating components, so it provides some sort of provide a hinge fixation, so we can actually create an angle between the proximal and the distal ring blocks. And applying this following the knowledge that we know about deformity corrections, I will not go in details about deformity correction because it's another topic for a couple of days. If we, let's say, create an angle between these blocks, the proximal and the distal ring block, which is the same for the magnitude of the deformity, for the size of the deformity, for this malunion, and we apply it in the correct way, then we can simply cut the bone and then progressively correcting the distal block in relation to the proximal one in order to achieve like parallelism between, you know, these two blocks. So these rings to become parallel one to each other. At the same time, we're gonna correct the deformity, and at the same time, we're gonna preserve the normal length of the bone, which could be also important if the bone is already shortened too much. So this was the application of the frame. So it's a very simple way to treat any bone deformities. So this is a simple bone deformity because it's just in one plane. So we have just a valgus deformity. And again, if we position in a correct way the apparatus, it's easy to correct it. Actually, to correct such a deformity, you spend much more time in terms of planning before surgery, and then the surgery is going to be very fast surgery. Just application of the frame, cut the bone, and then you have to do, of course, some work for progressively straightening of the leg. This is the same dog after the treatment. As you can see that in the fracture line we have in the malunion, or let's call it osteotomy line, we have a good bone during the process of progressive straightening of the leg. Actually, the hinges are the components that allows you this angulation, this movement. Depends on where you position these hinges, you can not only strengthen the leg, but you can actually lengthening the bone. So if they are offset, so if they're away from the level of the bone, which was not the case in the previous malunion case that you saw, but if they're a little bit far, and this can be calculated actually, this offset, how much lengthening it will gives you, you can produce a bone lengthening. As I mentioned, for me, one of the best indication for llizarov fixation is when we treat bone deformities, angular bone deformities, and especially complex bone deformities. Because the malunion case that you saw had only one component of the deformity, and that was a frontal plane deformity. It was a valgus deformity. But cases like this dog, which is a giant breed dog, with some sort of unknown trauma to the distal growth plate of the ulna, usually results in complex bone deformities, which usually have actually three components, which are frontal plane deformity, a valgus deformity, external rotation, external torsion of or external twist of the antebrachium, and increased procurvatum in the sagittal plane. So we have three different components of the deformity, which makes the deformity very complex and very difficult for being treated. In these cases, we are using a so-called graphical method. Again, we spent much more time in planning. And again, I don't want to make things very, very complicated, but then this makes actually relatively easy the surgery if you spend more time in planning, of course. And in this case, for example, we were correcting both components of the deformity in acute way, which were the valgus deformity and the torsional deformity, by simply removing a wedge from the bone and simply rotating the distal ring in comparison to the proximal one. And then progressively, we treated the procurvatum. And this progressive way of treatment of bone deformities give us the opportunity to have the tendons on our side, because probably the most difficult part in acutely correction, it will be, if you want to preserve the length of the bone, it's going to be the tendons which will fight against us during the whole process of correction. So in these cases, for me, the biggest advantage with llizarov is that by making things progressively, the tendons can adjust to our correction. Okay, so this is the so-called graphical method. So we need to have some knowledge about So we need to define what is the size of the deformity. We need to define where is the exactly deformity located on the bone. This is following the Cora methodology. So we need to find the center of rotation of angulation. We need to find also the vectors or the direction of our deformities. And by knowing all this, we can make the frame, and we apply the frame in a correct way in order to correct the deformity. So this is how it looks like during the deformity correction, and this is also some time later. So the motor is the one that is fixed to the caudal aspect of the frame, and it was used to correct the sagittal plane deformity. Again, here the forces will be the biggest forces will be here because of the tendons, of the flexor tendons. This is the dog during the treatment. Again, despite that, we are doing things progressively. As you can see, the red tape is the red vet flex is actually to support the carpal joint, to support the paw, because during the correction we have a lot of tension on the flexor tendons, and this also brings the carpal joint in flexion. So this is kind of physiotherapy that we can do together with the correcting of the deformity. This is the frontal plane after the correction, and this is the sagittal plane after the correction. Again, I will not go in details. This is another case. I don't know if you see cases like this. We do see a lot of them. These are young dogs with a so-called carpoflexural deformity. So it's nothing to do with bone deformities. It's the fact that the pathogenesis, the mechanism of this disorder is that the bone is growing a little bit faster. The tendons, especially the flexor tendons, of the antebrachial flexor tendons, are growing a little bit slower. So this put a lot of tension on this flexor, so the animal cannot walk. And actually, sometimes there are different grades of the disease, but sometimes when they are in third grade, they really cannot walk. And this is a self-limiting condition. Actually, we know that this dog, it's going to be okay without doing anything. So this is the dog at younger age. And we were discussing with the owner, because this dog is coming from, lives in another city far from us. And the owner sent me some videos, and I think the dog was like 4 or 5 months old that time. And I told him, just wait. Just correct the foods. Do not give any extra calcium, and etc. etc. Do not promote faster growing of the bones, and it's going to be okay. Okay, but in approximately 1 month later, 1 month and a half, the condition was the same. The dog was bigger, but it's still not able to walk. And then I decided that I have to go for something to support possibility of extension into the carpal joint. And what we do actually I have treated this surgically just in a couple of cases, but what we do is actually we cut the flexor carpio-ulnaris muscle from the insertion from the carpus. We simply cut it, and sometimes this is enough to restore a normal extension into the joint, but not in this case. I mean, I cut it and then nothing changed, so I had to build this frame, articulating frame, in order to progressively stretch and extend the carpal joint. So we did this first to the left side, and this is the result after we actually removed. So this video has been made just before we apply on the right side. So after that we did on the right side. Unfortunately, I don't have a video after removal of the frame from the right side, but my point is that you can see the difference, and you can consider this as an option for treating this deformity, maybe a rare case. Also, as I mentioned, bone transport and destruction osteogenesis are another unique indication and properties for circular fixators. Actually, this was discovered by chance from llizarov. because actually a patient that he supposed to provide compression to the fracture line was turning the nuts in the opposite direction. Instead of compression, he was performing a distraction. And then llizarov discovered that there was a new bone between these two, distracted fragments. So in these cases, a part of the bone is moved apart from another gradually. We do it in a rhythm and in a special rate. And this neovascularization stimulates new bone formation. As I mentioned, this lengthens not only the bone, but also the soft tissue, the nerves, and the skin. So sometimes people are using this for lengthening of soft tissue as well. Before we start lengthening, we usually, after we cut the bone, we usually wait between 3 and 7 days. This depends probably on the age of the animal. And then we start a distraction rate, which is usually historically has been recommended to be 4 times per day, 0.25 millimeters each time. But because this is usually done by the owner and it's quite impractical for them, we most of the time do it 2 times per day, and we recommend 2 times per day, a 0.5 millimeter each. Okay, so this is how the X-ray would looks like. So if you want to lengthen a bone, then you cut it, and again you wait some latent period, and then you start distraction, and this has to be followed by regular X-rays to see how the new bone is looking. So at some point you're gonna see much stronger bone, and at this point that you have to stop and wait for bones consolidation. And I'll show you also some cases. This is a young, I think it was a mixed breed dog with another type of, let's say, relatively common type of antebrachial bone deformity, when we have actually premature closure of the distal growth plate of the radius. So it's not the ulna this time, it's the radius. And because the distal growth plate of the radius gives approximately 60% of the entire length of the radius, this growth plate, it's actually very important for the entire length. And in this case, probably there was some trauma which caused eccentrically premature closure of the distal growth plate of the radius. So for this reason, in this dog, we had a frontal plane deformity as one component of the deformity, and then probably this affects mainly the cosmetic part, but then we have this big step into the between the radius and the ulna, which creates a radio-ulnar incongruency, and this could have a devastating consequences in terms of development of arthritis in the future. So what was the plan here? The plan was to cut the bone at 2 occasions. So one is the distal to correct the angular component of the deformity, and this will be done acutely. So we do it during the surgery and fix it that way. And then another cut of the proximal aspect of the radius in order to progressively correct the incongruency between the radius and the ulna. So this is how it looks like after the surgery. Again, the distal part was corrected. Not easy to correct even the frontal plane deformities in these cases, because especially if you have a severe deformity, angular deformity. And then the proximal cut, you can see it for lengthening of the proximal radius and restoring the normal congruency into the elbow joint. So this is probably one of the cases I have treated, maybe at least 10 cases with this technique, especially when we have to combine 2 different osteotomies for restoring length and for correcting angular bone deformity. But this is the case when we achieved perfect congruent into the elbow joint. And not only that, you can see it on the X-ray, but also the fact that there's no any sort of suffering of the subchondral bone into the ulnar notch, something that we see in the elbow dysplasia, like a sclerosis. Here the bone is nice and like a normal subchondral bone without sclerosis. This is a different case, probably more severe case when we have even more severe angular component of the deformity and more severe radio-ulnar step, radio-ulnar incongruency. This case I'm showing you because there are some complications related. So I was treating, this is the way how I treat the angular component of deformity. So I use a jig to keep everything in the same plane while I'm correcting the deformity. I was not actually able to achieve a good correction of the angular component, but probably this is not so important here. I was, despite that, during the lengthening process, I was able to somehow align the distal fragment to the carpal joint. So there was a clinically and also radiographically much better, the leg was with a better, much better function. You can see also the proximal osteotomy with the lengthening of the proximal aspect of the radius. In this case, what I had as a complication is something that I learned from this case, is that you have to stay away from the really proximal to the joint, because the pin is going through the joint capsule, and because there is a lot of motion close to the joint, always there is some sort of infection, a pin tract infection. And this pin tract infection is going right to the joint. So we end up here with also septic arthritis. So I had to remove the most proximal pin in order to treat the septic arthritis. So this was the outcome in this case. Again, not very good correction of the angular component of the deformity. Probably not so perfect also restoration of the congruity into the elbow joint, but functionally the doc was doing much better. This is a similar case. It's a relatively recent case because I also want to show you because of possibility of some sort of complication. This is Ira. It's a 5-month-old German Shepherd dog. You know, presented with a similar situation with her left forearm. Actually, she was presented to us relatively early, at 5 months of age. So I took advantage, you know, if we have a case like this, to correct the radio-ulnar step in a different way. So for us, by prioritizing what we have to do first to save the joint is the most important. So I was not focused on the correcting, you know, the angular component of the deformity, but was mainly concerned about the joint problem. So I performed a distal ulnar ostectomy, and you are probably familiar with this procedure, that it's something that could restore a radio-ulnar incongruency in a short radius syndrome if it's done before 6 months of age, because of the elasticity between the elastic connection between the radius and the ulna, so that the interosseous ligament is very elastic. So if you do it before 6 months of age, when the animal is, you know, using the leg, the proximal segment of the ulna will goes down and will restore a normal or almost normal congruency. And this happened, and something that I was considering in this dog was the fact that actually I will have a consolidation pretty early, and then the dog will still have some residual growth of the skeleton. So maybe we'll have like a relapse of the radio-ulnar step. And despite that, I was using a bone wax. A bone wax we are using to, you know, to fill the defect after we remove the segment of the ulna, to try to prevent for early consolidation. The bone, it did heal relatively soon, and then the radio-ulnar step relapsed again. So for correcting this, then I moved to llizarov correction, when I did pretty much the same correction of the angular component, and destruction of the proximal one in order to restore a normal radio-ulnar congruency. In this case, again, I was not very happy with the correcting of the angular component of the deformity, so I took advantage of using a different components, which are washers, which are spherical washers. So despite that you don't have the hinges to give you, the correction, you can add additional between 7 and 10 degrees of angulation between the proximal ring block and the distal ring in this case. Something that I was not very happy here was the fact that while we started lengthening, I was not really happy to judge what is happening into the elbow joint, and this is the the wobbly family of IRA. And when we remove, at some point we removed the external fixator and actually find out that I overcorrected this radio, so I lengthened it more than I should, and we created actually opposite step. Again, this was not in a major clinical consequence for the dog, so I didn't do any further treatment, so the dog was doing functionally well. But again, creating a bulky llizarov apparatus, it may interfere with what you see on the follow-up radiographs, so you have to consider this, make sure that you have room to see everything during the x-rays. I will show you another case of some sort of bone transport using llizarov. This is a 4-year short-haired domestic cat that was missing for approximately 1 week, 10 days from home, and then came back with a type 3 open fracture. Probably it's a type 3, I'm not really sure, it's type 2 or type 3. So this means that this part of the bone was actually outside of the skin and outside of the soft tissue, and was already black and non-functional. And then I was thinking, what should I do in this case? Because we also know that the distal tibia is not the best location for normal healing in feline tibia. And so I was pretty sure that I have to do something more to improvise a little bit in order to save the leg of this cat. So the aim was to remove this part, then fix it to the distal part, and then applying a llizarov to create a new osteotomy proximally in order to lengthen from the proximal aspect. And this is what we did. So that distal segment was removed even further, even more, because I was really wanted to make sure that I'm in a good healthy bone. Then we applied the llizarov frame, and then after we applied the frame, we cut into the proximal tibia. We actually lengthened from the proximal tibia, from the proximal aspect of the limb, because in this area we have more muscles, so the muscles prevent less lengthening of the bone instead of tendons. Tendons are always give us much more tension, so always when we want to make a lengthening, we try to cut in the area where we have the the body of the muscles, the muscle body, not the tendons. And this is the cat with the frame applied, and this is during the lengthening of the proximal tibia. You can see that a new bone is forming. At some point, I was not really happy after we removed actually everything. I was not very happy with the bone consolidation. So I was really didn't want to take the risk of something to to break after that. So I decided I want to put a plate, so just to prevent from further fracturing. And this is the cat after the treatment, that you can see that it's also using the leg reasonably well. So I have used also, speaking about cats, I have used llizarov for some congenital deformities or agenesis, especially into the tibia, especially in these hemimelia cases, when the tibia has been actually very short and very deformed. Sometimes they don't have, you know, a full part of the tibia. Sometimes they have a bigger fibula than than the tibia. And so I have treated some of these cases. Some of these cases actually needs a very complex treatment with combination of lengthening, corrective osteotomy, and fusion of the joint. So definitely it's not the first case that you have to start with llizarov, but just to show you that, you know, the method allows you to be really artists in making in building your frame, so you can treat a lot of things. Hybrid ESF, I mentioned from the beginning that it combines circular and linear components. In these cases, we are using a threaded pins, combination of threaded pins and transfixation wires. It's actually relatively simpler and quicker compared to building a circular frame. So that's why we say that it has an increased versatility, and it's more appropriate for upper bones. So let's say if we want to use it, some sort of, if we find that there is some indication for circular components into the upper bones, femur, especially humerus, it's better to use a hybrid frame. And I will show you some cases. So this is a traumatic case. It's a fracture in a young dog, very distal fracture, when I have applied this hybrid frame. This is a case with an open fracture. This is a type 3, definitely open fracture, type 3B probably, because nothing can be reconstructed in terms of soft tissue. Really compromised biology here, and everything is exposed. So not really many options here in such a cases. I was thinking about applying a ring in a distal fragment, and I was thinking that maybe I can focus even on what is left, under the above the growth plate, so to not to create any growth plate problems, problems to the limb. But actually during the surgery, that little piece of bone additionally fractured, so I have to go with a transarticular frame, and I built this hybrid frame. So with one ring, actually hybrid rods proximally and extension pins distally into the metacarpal bones. This allows, the soft tissue to heal relatively soon, relatively fast. So granulation tissue first, and then epithelialization. So everything was closed in terms of soft tissue. So I was not really happy with the bone consolidation again, and that's why I went back and put a plate after that. But then we had already, healed soft tissue, so the plate can be covered with the soft tissue. So this case is not against llizarov, as an outcome, because I have used the plate at the end, but neither the previous one. But actually, llizarov was a kind of treatment in the middle, which without the method, we probably could not reach the final outcome. A hybrid frames apply to the upper bones. I will show you two cases of lengthening of the humerus. Not very, probably quite unusual cases. This was a case with an unusual trauma of the distal growth plate of the humerus at relatively young age. So the dog was really suffer from severe length deficit of this humerus. We know that our patients can tolerate approximately 20% of shortening by compensating this by simply walking with more extended limb, with more extended joints. But this is true probably for the hind limbs, where the joints are relatively in a flex position. For the front limbs, they're already extended, during normal locomotion. So I considered, this case that it's a good candidate for lengthening of the humerus. We didn't have any latent period here because that was a young dog, so I didn't want to have any premature consolidation before I achieve, my goal. And the goal was about 3 centimeters. I think we achieved 2 centimeters as total, but this was enough, you know, to improve the gait of the limb. And this in this dog we had a good solid cows in 22 days. So you can imagine how fast they can heal in a growing bone. And this is an upper bone, so much better healing potential because there is a lot of soft tissue around it. The other case, it's also a little bit unusual case. It's old male chow chow presented to us with a bone tumor in the proximal humerus. The biopsy came as a fibrosarcoma, as far as I remember. Was not osteosarcoma, was either chondrosarcoma or a fibrosarcoma. Of course, in these cases, we went to CT in order to find the borders and etc. We were discussing with the owner what we can do as a limb salvage. Can we, preserve the bone? Can we preserve the limb? So the only option here was to remove the proximal segment with a clear margin. So this means almost a half of the humerus was removed together, with the joint, disarticulated from the scapula. And then what I did is fixation, fusion of the rest of the humerus to the scapula. So this was arthrodesis, actually, shoulder arthrodesis. And then a hybrid frame was applied to the rest of the bone, and then additional osteotomy was done above the supratrochlear foramen. And I was actually started moving the distal fragment away from the rest of the bone in order to create a new bone. So this was really, I was not really sure what I can achieve, but again, we achieved some sort of lengthening. Actually, it was enough for to compensate the length deficit in this dog. This is how the frame looks like. So you see the new bone formation in the osteotomy line. This is probably approximately 20-25 days after we start destruction. And also here you can see a better consolidation. And then at the end, again, I really was not sure enough that this can hold. The bone was not a bullet, it was not a solid bone, so I apply a plate to support my new bone cows. Unfortunately, this dog developed again, this time a soft tissue tumor at the area of where we have removed the tumor, and I think was put it to sleep approximately 4 months after the previous surgery. And then at the end, I just want to mention that there is kind of evolution of the original llizarov fixator, something that it's called Taylor special frame or hexapod. This is a huge dog. This is approximately 80 kilogram Middle Asian Shepherd dog that was treated for that was presented with us with angular limb deformity, again, very complex deformity. So it was a big challenge for us because even the biggest llizarov apparatus, I was not really sure if it's going to be strong enough for this dog. And also there was another factors, the clinical factors. So this is the owner of the dog. So you understand that we need to have a good outcome. And so this is the dog. So in this case, I decided to use this hexapod. The hexapod, in terms of stability, has the mechanical advantage, and also the other good thing is that it's controlled by computer. So software gives you the recipe, how much you have to turn for each of the connecting rods. And also, you can actually correct everything. I mean, as far as you do a good planning, actually, it's not even the planning is not so important here. The postoperative radiographs are important in order to, create the recipe from the software to to guide your correction. So all of the correction is done actually after the surgery. So in this case, we removed again a wedge from the bone. So we shorten the bone a little bit, and we correct only the frontal plane deformity, only the valgus with the hexapod, and then progressively we correct the torsion, and we correct the torsion, we correct the procurvatum, and also we lengthen a little bit the bone, because again, removing of wedge means a shortening of the bone. So I think I'm done with this slide. I will probably stop share my screen right now. Abhishek?
Yes, sir. Yes, sir. You can. You can stop then.
So I don't know. Do we have an option for questions if they have arisen already, or we can do some discussion maybe if there are some questions at the moment? Let me know. Just I will be here. If
I will ask the question, sir. I am monitoring it. The session was very nice, sir. Thank you very much for doing this to us. We have some few questions from our audience. I wanted to ask it to you. One among which is how to deal with the infection that is transferred from the environment to the bone marrow while fixing the transfixation pins.
Okay. So actually, in both methods, linear or circular external fixators, they are highly resistant to infection. So I have never seen infection along the medullary cavity. It's not like an intramedullary implants. Actually, it's exactly opposite. I mean, we are using external fixators to fight with the infection.
Yes, yes,
so,
definitely.
So definitely, there's no such a, I think, situation when you can create an infection. And of course, despite that the method is resistant to infection, it has to be done in a sterile environment, right? It has to be done in the surgery room.
Yes. Another one is, what are the common complications in which fixations, like in circular or whether in the linear, in which conditions we will find a more common complications?
So from mechanical point of view, maybe I would say that maybe with the linear one.
Linear.
Not for other reason, but because linear fixation is it's more simple, right? So I think it can be done from many veterinarians.
Yes, sir, yes, sir.
So the probability of having complications would be higher with a method that is used in, let's say, non-experienced person.
Yes, yes.
Opposite, llizarov is more complex fixator. For sure, the person that is going to use it should know more about as general about fracture treatment, maybe about angular deformity correction, etc. So for me, less possibility of complications.
Okay. Thank you, sir. What kind of a bone graft do you use while lengthening of an bones or for angular deformity corrections and all, sir? You have mentioned one bone wax. I think they need some extra information regarding that. Yeah,
bone wax is something to it's to control bleeding. So if you have bleeding from the bone, you apply a bone wax as a mechanical device to stop the bleeding. So it prevents from bone healing. Okay, it doesn't stimulate bone healing. So in this case, I was using it because I wanted to increase the length between consolidation of increase the length of consolidation of the ostectomy.
Okay, sir. Thank you, sir.
Alternatively to bone wax, you can use a fat, from the same animal. So insert that fat inside. Alternatively, you can use a Penrose drain, but the Penrose drain, then you have to go back and remove it after that.
Yes, definitely. Another one question, sir. You have mentioned about the tie-in fixation, hybrid tie-in fixation. What kind of a fractures is well suitable for usage of the tie-in fixation, hybrid tie-in? Yes.
So tie-in fixation is a combination between type 1 and intramedullary pin when the connecting rod is attached to the IM pin. So we know this increases the mechanical stability of the construct, and this is the reason why we combine it. The best would be, again, humerus or femur as the best, most suitable bones for tie-in configuration. Tibia could be also combined. In tibia, for example, you can do it as well, but it's more morbidity, there is more morbidity related to a tie-in configuration in the tibia. Also, tie-in can be combined in the antebrachial fractures, radius ulna fractures, if the pin is applied inside the ulna and the external fixation is applied to the radius. Okay, two different bones in one IM pin, the other one external fixation, and again connected together in a tie-in combination.
Okay. Thank you, sir. Another one question. For radius and ulna fracture, especially for the radius, under linear fixation, type 1B is suitable. Whether the type 1B is suitable or 2A is suitable, they are a bit confusing maybe to select between type 1B and between type 2A.
Yeah. So the radius is a very unique bone because it has a natural procurvatum. Okay, the cranial aspect, there is a little bit of bowing in the sagittal plane. Okay, from, let's say, from medial to lateral. And because of this procurvatum, sometimes we have problems with building type 2 configuration to the radius. And the solution for this, to create a good, stable construct, is to make a type 1B. So if somebody is experienced enough to make a type 2 to the radius, that would be probably also a very good option. Just in my hands, very often I have to build a type 1B.
Okay. So another one practical question here, it is, what is the critical stage in practically application during the circular ESF application? Critical stage means that we should have to keep more observation over that. A difficult point while application of a circular ESF.
I'm not really sure I understood the question. Can you repeat it maybe?
Which is the critical stage in circular ESF application?
Critical, you mean probably the critical, like which?
I too don't know, sir. They are asking like maybe because which stage we should be, means very difficult, means key.
Okay, so I would say that maybe the stage for the surgery of applying circo-external fixator could be the planning and the execution, right? So, the planning is really, really important in circular fixator. The execution could be probably much easier if you have planned things very well. Maybe the question could be related also to the postoperative period. If it's a critical, yes, I would say, like the rest of the external fixation as a method, it's a critical period, and as I mentioned, it needs a very dedicated owner.
Okay. Thank you, sir.
I don't know if this can answer that question.
Maybe, sir, the question itself is not that much understandable. There is another one question, sir. Have you ever felt like plating would have been better compared to the ESF or circular?
So the question is to compare plate fixation with a external fixator? What?
Yes. Have you felt any time plating would have been better? Plating would have been better compared to the ESF. Have you ever felt like that?
So the question is, have I faced a complication with a plate fixation, which then I have to convert to an ESF? Is this the question?
No, sir, it is not like that. The doctor is asking that while using ESF, have you ever felt like ESF is more useful? Plating is more better compared to the ESF. If you want, our sir is there. If he wanted to ask the questions directly, I can ask him to unmute himself and he can ask the question.
Hello. Can you hear me? Hello, doctor.
Yes, sir. Yes, sir. We can hear you, sir. You can ask the question directly.
In retrospect, have you felt, oh, we should have done plating than external fixator in any circumstance in the past?
Not really sure I can understand the question. Is it to compare both methods, or which one I have more experience and I use more in my practice?
Okay. The fracture fixation, we have different methods like plating, okay, pinning, external fixators and whatnot. But sometimes we see in hindsight, oh, I wish I should have taken this as a better method than the other, something like that.
Okay, so I think I understand. I think I understand the question now. So both methods are definitely completely different methods. One is more, I would say, we used to say that plates and screws are friendly to the patient. External fixator is more friendly to the surgeon. In terms of, let's say, if I want to use external fixator in a certain fracture configuration, I know that with both systems, I can provide a good stability. So again, from mechanical point, they will be okay. From biological point, maybe a difference, because for the plate, I probably need to do a big incision, big dissection to the soft tissue and etc. So this is not a biologically friendly approach. Maybe it will be if I apply it in a minimally invasive way. So it's going to be a minimally invasive plate osteosynthesis. Opposite with external fixation, it's going to be really biologically, approach for this fracture. And then from clinical point of view, again, it's friendly really to the animal, the plate and screw systems, not so friendly for the external skeletal fixation. I would say that in a clinical, in a fracture situation, if I have to choose between external fixator and a plate and screws, I will probably use the plate and screws. Okay? Okay. But there are situations, there are fractures in which definitely external fixators give us, advantage.
Okay. Thank you. Thank you very much, sir. This is all about our question and answer session. And finally, I would like to heartfeltly thank you, sir, for volunteering your time with us today. And I hope all of our audience has learned many things regarding the circular ESF and linear ESF. In our condition, usually we used to practice the linear fixation, but very less we practice the circular. But today, by learning from you, I think most of us will going to read more about it and will going to apply it practically in their clinic and hospitals. Thank you very much for your immense knowledge sharing with us, sir, today. And I would like to thank our university management for providing an opportunity, and also our IT department for our communicative help and all. Thank you, sir. If you want to say anything, you can.
I could thank you again for that invitation. It was really nice and pleasure to to speak to you. So hopefully we will see you maybe personally someday. I don't know.
Yes, sir, definitely we will, sir. We will welcome you to India, sir, once.
Thank you.
Thank you, sir. Thank you, everyone. Stay safe, stay healthy. Thank you. Bye.
Bye-bye.